everybody. I am so excited because today we have a special guest, Dr. Vera Hendrix, who is a breast surgical oncologist with Mary Bird Perkins in Covington. How are you?
Yes, good. Thank you for having me.
Oh my gosh, it's such a pleasure. I've been really wanting to get to know you better. I'm completely aware of you, and I know you've been to some of our functions, and your name is mentioned everywhere. But this is a really honor for me to sit down with you today. So thank you so much.
Me too. Thank you. I love all the events. I've been to all of the United events since I've started working with Mary Bird Perkins in the last 2 years, and they're wonderful. If you haven't been, you should go and participate. And we have several patients that are interested in being in next year's cycle and going through the whole process. So we'll
When
have
you,
to touch base about that afterwards.
yes, when you say next year, do you mean now, this year?
Now,
Good, because we're taking
yes.
signups right now for
Okay,
what is
perfect.
called the Fight Club. That's our theme this year.
I love
Boxing.
that.
Yeah,
Brad Pitt.
yes, yes. Well, really more like the Rocky,
Yeah,
climbing, running up those steps and,
I love
and
that.
declaring victory. Well, I don't know if you are aware of the fact that I've recorded in the last or published about 55 episodes on the podcast, on the Still I Rise podcast, and this is my first professional one. And what I mean by that is having an expert join me to be interviewed because I really want to sprinkle in your knowledge. And, when we get together with all the ladies and, there's constant conversations and questions, who better to hear it from your perspective of what you've e- endured and dealt with and learned in all of your education. So, speaking of that, let me just do a proper introduction.
Yes.
So, Dr. Hendricks graduated from Georgetown University School of Medicine in Washington, D.C. She completed her surgery residency at Tulane University School of Medicine and her breast surgical oncology fellowship at the University of Southern California. She is the only fellowship trained breast surgeon on the North Shore. I really want to talk about that. That's amazing.
Yes.
And is renowned for her clinical experience and dedication to exceptional patient care. And to me, all of that's impressive. I think that last sentence really means a lot to me. You hear so many times of patients who, just don't have a good experience with their team or a doctor, and obviously that comes from deep within you to be able to do that. Just
Definitely.
tell me a little bit about you. Where did you grow up, and how did you end up on the North Shore?
Yes, so it's a very interesting story. I feel like sometimes I should write a book about my family, but my mom is from Ukraine. She actually came here as a Jewish refugee in the late 70s from the Soviet Union, and my father is from Taiwan. He came here as an international student from obviously from Taiwan to do his PhD in organic chemistry at Columbia University in New York City. So people always ask, how did they meet? Your mom's Ukrainian, your dad's Taiwanese. And I always say in New York City in the 70s, obviously no drugs were involved because it was the hippie era. Um, but yeah, so I was born and raised in New York City. I went to college at NYU. I actually studied political science and international law. And I just decided my senior year of college, of course, that I wanted to study medicine and pursue medicine. I always knew that I wanted to help people. And I realized that what I initially thought I wanted to do, whether that was working for a governmental organization, NGO, or international law, it wasn't going to be as universal as medicine. You can go to France and do an appendix surgery or an appendectomy very similarly that you can do it here in the United States. So I like that universality of it. And I did a post-bac at Harvard in Boston, and then I was accepted to Georgetown in Washington, D.C., where I did medical school for 4 years. It was a wonderful institution, a beautiful location. They did emphasize mind body medicine and cura personalis, which means curing the whole person, not just the disease, but taking into account everything they're going through and synthesizing a treatment plan that's individualized and personalized to them. So I bring that with me to residency. I brought that with me to fellowship, and I bring that with me now to Mary Bird and taking care of my patients.
That's impressive. Tell me what it means to be the only fellowship trained breast surgeon on the North Shore.
Yes. So I think that I have to put a qualifier to that now because I think there is another fellowship trained breast surgeon, but I'm the only female fellowship trained breast surgeon. So
Okay. Okay.
I still meet those criteria, but it is an honor to be able to take care of patients and have that background of that additional year of training in just solely breast surgery and breast cancer. Um, Most people go through 5 years of general surgery and they can practice breast, but fellowship trained breast surgeon means we went through an additional year of training that's only specialized in breast cancer and breast surgery, and that's so important, and you want your breast surgeon to have that because there are so many advancements in medical oncology, radiation oncology, breast surgery, the techniques, clinical trials, and you want a person who has that background, and stays up to date and goes to the breast surgery conferences. So I think it sets you very far apart from the rest of the, maybe general surgeons that practice breast but didn't necessarily do a fellowship.
Absolutely. How did you end up on the North Shore?
So I did residency at Tulane, so I was already here in Louisiana. This is my ninth year in Louisiana. I moved
Mhm.
here in 2016, um, and my husband was here. He was a plastic surgeon, hand surgeon at University Medical Center, actually, and so he was already a junior attending practicing when I went and did fellowship. So I came back, obviously, to be hit with him here, and I just love New Orleans. I love the patient population. I love all the training, and I happened to, interview with Mary Bird Perkins and Dr. Lagarde, and there was a need on the North Shore. There was not a fellowship-trained breast surgeon at that time here, so it was just, a combination of worlds, and I just love the Mary Bird Perkins brand. I liked that they did a lot of philanthropy. They really cared about their patients. It wasn't that patients were just gonna be another number and a 15-minute office visit. They met patients where they were at, and they took the time, and they had a lot of detail and care towards their treatment, which I loved.
Yeah, Mary Bird is very special. And also Doctor Lagarde's husband is a hand surgeon, right? So
Yes.
was that just coincidental?
Yes, so actually the first time I came down and interviewed, my husband came with me, and, we met Dr. Lagarde and her husband, and we were like, "We're both breast surgeons, and both of our husbands are hand surgeons, what a
Yeah.
coincidence." Except that my husband did mainly hand surgery, and I think Dr. Celentano did a little bit of breast still and was able to work with Dr. Lagarde, but I think there was that little incentive of us, maybe eventually taking over their practice, being a couple that were both surgeons doing breast and hand.
That's really a coincidence. Tell me what you do outside of work just to, like, escape I mean, I don't know if it's a mentally tough profession, we'll get into that a little
Right.
bit, but what do you do for fun?
So I have a 2-year-old daughter, so she is all-encompassing, and she is just the love of my life, so precious, but also a little bit wild, and she's entering her terrible 2 phase, so sorry, excuse me. So a lot of outside of work is going to the playground with her, going to the children's museum, and just seeing her, um, view the world and learn and listen to things, and so I think a lot of my time outside of work is really focused on my daughter.
Mhm. Now, you did share with me a personal story that I
Yeah,
was hoping that we could maybe talk about.
definitely.
I found out today that you are a mom of the 2-year-old you're
Yes.
talking about, but that your husband recently passed away because he got diagnosed with a brain tumor.
Yes.
So, I just am trying to get myself into your shoes, your head of what it's like to be an oncologist who then had a loved one who got diagnosed, and then being a new mom, and how do you I mean, how does all that, like, the worlds collide in your life, and how have you been handling that?
Right. I always say, whenever I have patients that come in and they're saying that all these things all happen at once, I just refer back to Murphy's Law. So everything kind of did happen at once. I was graduating, fellowship. We had, just had the baby or, found out that we were pregnant basically, a month before he had his recurrence. So it was a lot of things happening at once. I was studying for boards. I was starting a new job. So it was I definitely think medical school and residency prepare you for life's toughest challenges.
Mhm.
But regardless, it was very, very difficult and very hard. He was a plastic surgeon and hand surgeon, obviously, and he was diagnosed with, glioblastoma, which is a form of brain cancer. Um a little bit after he turned 38 years old, and he was obviously a doctor, surgeon, thought it was just migraines, from being on call, and, working, hard and stress or whatnot, um, and then he was diagnosed, he did wonderful, he went to Duke, so shout out to Duke, which is a great, a national brain cancer center, and he was in an immunotherapy trial there for, about a year, and he did wonderful for basically 18 months, almost 2 years, and then he had a recurrence a month before, um, we found out that we were pregnant, and right as I was graduating fellowship, so I was able to come down here, and be with him, and being, I think, a little so he was very realistic. In medical school, you learn that glioblastoma is a death sentence. You learn one sentence about it, um,
What is that sentence?
that it's a death
That's
sentence.
the
That's
sentence
the
you learn.
sentence.
Oh,
Yeah,
boy.
that it's incurable. There's no known cause. There's no cure. That usually the prognosis is about 12 to 15 months.
Mm.
Um, it's kind of like pancreatic cancer almost. That's another deadly form of cancer that usually has a short life expectancy. And so he was very realistic in that sense. He was like, okay, I have this diagnosis, I have to get my affairs in order. And I was kind of very in denial. Being a doctor and being a surgeon, I'm just very used to a patient having a problem and then fixing that problem, especially in surgery. Like if you came into the emergency department and you had stomach pain diagnosed with appendicitis, we remove your appendix, you're better.
Mm.
Very tangible effects. And so to me, that was always my ultimate goal, and, I just never even had in my mind that he wouldn't survive that it was even an option for such a young, healthy genius of a person and a human being, so kind, so handsome, which is another story, but, to be diagnosed with that and then, for glioblastoma to ultimately take his life it was just not even an option in my mind, and it might have been a little bit of denial or just my medical background, um, thinking like there must be some cure, there must be some way that he has to survive. There's no way that he could, pass away from this.
Well, you must bring a lot of that, experience to your, relationships with your patients when they might sometimes, you see a doctor in a white coat, think "Oh, they can never understand what I'm going through." But you personally, firsthand know, especially from the caregiver side.
Yes, from the trials and tribulations. I will say something about the caregiver side. He was actually on FMLA from his job, and that's 12 weeks.
What does that mean,
So
FMLA?
FMLA is Family Medical Leave
Oh, okay,
Absence.
okay.
So I think they have it outside, obviously, of the medical field in any job. But if something happens, or you're sick, or ill, and you have to take leave, it's 12 weeks of leave, and I believe a portion is paid and another portion's unpaid. So once he met those 12 weeks, he didn't qualify for anything, so he wasn't getting an income, and on top of that, he was going to have to pay for health insurance, which was gonna be 3,000 plus a month because that employee or that person has to take on the portion that the employee paid
Oh,
previously, like the hospital did.
it's heartbreaking.
So it was heartbreaking, and so you can only imagine that as a caregiver, you want to be with your loved one, you wanna be able to help them, especially if they have a terminal diagnosis and you don't even know how much time they have or their prognosis is 6 months. Can you imagine trying to go to work? And you have to go to work because if they're losing their income from their profession and they're losing their health insurance, and you can't stay at home and caregive for them because you need to be the breadwinner, more so to say, and have the health insurance. So I felt kind of conflicted. Obviously, I wanted to work and I love my patients, but also we needed to have health insurance and have some kind of income because his Avastin infusions, which was one of the chemo infusions he was getting, or you can say immunotherapy infusions, was $20,000 a month through insurance.
Mm.
Um, so I definitely feel for patients. It's a very conflicting role to be a caregiver. Um, and wanna be at home with your loved one and take care of them, but also how can you do that with neither of you working and then neither of you having insurance, and then on top of that, having $20,000 infusions monthly to
Mhm.
save your life.
And on top of that, being pregnant,
Yeah,
dealing
exactly.
with the being pregnant. Well, how did you guys come to the decision of freezing your eggs, right? Is that what
Yeah.
happened? I mean, that's so did that happen at the time that he was diagnosed?
Yes. So it happened very quickly, and I'm sure a lot of people have gone through this. It's maybe talked a little bit more now, but basically, when you have a cancer diagnosis, you have a very short window between when you have surgery and when you start chemo, radiation, or any adjuvant treatment. And for him, it was about 3 weeks.
Mm,
So he had surgery, and then he was enrolling in a clinical trial at Duke. And you start chemo radiation, and you technically, when you're on those trials, they sign off and consent that they will not procreate because they're not sure what the trial experimental drugs are going to do to any possible fetus. So he had to freeze his sperm within 3 weeks, and I froze eggs and then recreated embryos, and it was very fast and it was a very honest discussion. Um, and I said, even if something happened and um, we don't end up doing it, at least we have the option, and I think to miss that window would be something that I would regret, and so it was definitely a decision, and I think from his standpoint, it was a little bit harder to envision having a child and knowing that you have this terminal diagnosis and your prognosis is 12 to 15 months and not being there, which ended up ultimately what happened, but, so, yeah.
the unexpected outcome of all that was a beautiful baby girl.
Yes, and she's so precious, and she just makes all his facial expressions and just reminds me so much of him, and I know, he would just be so in love,
Oh,
and she yeah.
thank you for sharing that story. If a patient had a similar situation happen where they had to make some quick decisions, are they counseled on those options?
I think to a certain extent, going back to the breast cancer world, we definitely emphasized it when I was in fellowship. We always offered it. There's a lot of younger patients that are in their 30s that may not be married or may not even have thought about being married or having children, and then they get this
Mhm.
cancer diagnosis.
Wow, good
And
point.
yeah, and when I was in California, I think the laws vary state by state, but, California at least was very progressive in that fertility had to be part of the coverage and you had to have options available. Whether that was actually implemented was a different story. So I think on paper and legally, they were supposed to, but I think in reality, I had met some young patients who said they were still told they had to pay out of pocket 10 to $15,000 to freeze their eggs. It wasn't covered by insurance. A lot of them are young. They don't have a dispensable
Yeah,
$15,000 to do that. And the time is of the essence too, even with that, because you try to, start sometimes neoadjuvant chemo within a week of a diagnosis, get a port in and start treatment, especially if they're young and it's aggressive. And a lot of times the fertility treatments are based on your menstrual cycle. So they're trying to time things. Oh, your cycle is going to start in 2 weeks. We're going to put you on these birth control pills, stabilize your hormones. Then we could do the egg retrieval. The egg retrieval doesn't always work, or you only get 2 or 3 eggs, and none of those are viable that they find out after the fact. And now you've started treatment. So there's a lot of moving parts.
and it still costs all that money
And it still
t
costs all that.
to
You
get
don't
that
it's
disappointment.
Yeah, it's not like a personal injury lawyer where there's a contingency fee and they're like, "Okay,
If your egg takes
yeah, we'll give you the money back, or we'll only charge you once we win," kind of thing, which is how personal injury lawyers work. No, you just lose that money. A lot of people pay thousands of dollars, and even just in private insurance, it's not covered.
well, that's another area that, our country needs to improve upon, I think. I mean,
Definitely.
just listening, I know that last year there was, got very close to having some legislation passed for the Fertility Preservation Act, and
Yes.
so I don't know if right now I think, they're in session with Louisiana State Congress, I think,
Yes.
and I hope that's being discussed.
Yeah, so I did a lot of that. So when I was in medical school in DC, I tried to incorporate my undergrad politics major, so it wasn't a complete waste of money to my parents, I guess. So I did a little bit of lobbying when I was in DC at Georgetown, and then I bring that here now because I'm part of CAGLA, which is Cancer Advocacy
Yes.
Group of
Yes.
Louisiana, and we often talk about legislative bills and cancer and how we can improve. And fertility is one of the bills that is constantly mentioned. I think we're moving in the right direction. I don't think it can happen fast enough. And as you know, with anything political or legislative, it's when they're in session, there's a lot of red tape, there's a lot of paperwork. It doesn't happen fast. And to go back to the glioblastoma brain cancer, there is an act in politics. It's called Right to Try, and it's really for patients that have deadly cancers, being able to try experimental drugs or experimental biotechnology, in a reasonable time frame, not wait 5, 10 years until it's FDA approved, gone through phase 3 drug trials, and the patient's already passed away.
Mm.
So I think that's another thing that's on paper a good thing moving forward, but getting it to actually be implemented is a different story, and I think that's similar to the Fertility Act. I think we need to move things forward more fast than they have been in the past.
Yeah, I'll be paying attention to that, and you said something that I just never thought about that I always thought is like a couple's decision to do that, but you were talking about if you're a young woman and you might not have met that person yet, that's like a huge thing to think about. That's
On top of a cancer
yes,
diagnosis and possibly being in shock from just, having that,
right.
to think about the future and so far ahead, and then financial, it gets very tricky and very intricate really
Yes,
fast.
it's exhausting just talking about it, let alone being in the shoes of someone who has to face those
Yes.
decisions. Oh, wow, it gives me a little bit of a headache in all honesty, but I do look forward to following your path with CAGLA on those subject matters. So please let me know of any advances that we can share that can benefit people.
Definitely.
So I have a few questions that I just am curious about. Um, so we talked a little bit about just the the perception of the like more cancer diagnosis is happening, or is it because we are getting better with screenings? I had a conversation the other day with somebody at Mary Bird Perkins, and they were looking at the parking lot, and it was full from front to back. Every space was full, and the person said, just about 3 or 4 years ago, this parking lot was half empty, and
Right.
same with the infusion suite. Now they said it's always full and, that you can see, like, younger people are sitting in those chairs getting chemo or they
Right.
is that an accurate observation? And is that something to be something to be alarmed about, or are we just looking at it from one side?
I think it's multifactorial. I do think that we're getting very much better at doing screenings. I think there's a lot more discussion publicly with the advent of online social media. People are a lot more honest and open about their personal cancer stories or trials and tribulations. And so I think because of that awareness, um, I think more people are getting um, screened. And in specific, in terms of breast cancer, we have a high risk program at Mary Bird Perkins, and we calculate a patient's lifetime risk of breast cancer. It's called a Tyrer-Cuzick score, a TC score. And if it's above 20%, that patient is considered at an elevated lifetime risk of breast cancer. And so oftentimes we'll do high risk screening, meaning we will start sometimes doing MRIs at age 25, and we'll start mammograms at age 30, and we'll do them every year, and we stagger them by 6 months. So they're getting some high risk breast imaging every 6 months to catch things early, and often
Is
while
that
they're
covered
small.
by insurance?
It is, and
That's a good positive thing to talk about.
yes, it is very positive, although I will say some insurances, there is a little pushback, and I'm sure you've heard of, peer-to-peers and prior authorizations. Sometimes we'll order an MRI for high-risk screening, and we will get a denial from the insurance companies, and then we will have to go and fight for the patient and appeal it and do a peer-to-peer and basically explain why they need this, and it's sometimes like, going after tooth and nail. I had talked to um, an insurance, representative, and they were like, "Oh, well, you guys calculated the TC score is like 21.2%, but I calculated as 19.998. How did you get above 20%?" I was like, it was very tooth and nail, it was obviously not with a fellowship-trained breast surgeon. I think it was an orthopedic doctor, who wasn't clinically practicing anymore, and I think that some of the insurance companies get bonuses for denying
Oh my
claims for
gosh.
patients, which is absurd, and we often talk about it at CAGLA, not just for imaging, for medications that patients really need for their cancer treatment, denied, and then they have to wait 3 months until they can get approval.
How much of your job is involved in going to bat for those technicalities?
So I think it happens few and far between. I think we definitely have a coordination of care. We have a nurse navigator now. We have 2 nurse practitioners. And so if I'm in the operating room, sometimes it's our nurse practitioner calling if they don't need to speak to the physician directly. But it is a lot of red tape, which I've said before, but it does hinder patient care. And physicians and surgeons already have a lot of what we call decision fatigue.
Mhm.
They're constantly making decisions, working in a multidisciplinary team, talking to the medical oncologist, talking to the radiation oncologist, the breast radiologist. And so there's a lot of critical decisions that are being made. And for something like that to come up and deny an MRI and have to spend an hour on the phone going through recordings to get to an actual real life human being to, only be told, "Oh, well, we didn't get the full history and physical note," or, "Oh, this or that," and it's unnecessary, and I think it's almost sinister and unethical.
Yeah, I
But
watched a special that was on TV. It took you into the, behind the scenes of an emergency room in California, and
yes.
from the doctors and some of the staff perspective of what they deal with these overcrowded waiting rooms, but one scene that really stood out was that a doctor in the ER was trying to order a procedure, and I think it was for somebody who didn't have insurance, and so it was getting denied. He was like, "I can save this person's life right now,
Right.
but I can't."
Right, and it's absolutely absurd. I don't know if you saw on social media, there was a plastic surgeon who was in the operating room doing a surgery. I think they were doing a flap surgery, so those are usually like 6 to 8-hour procedures. Got called by, I think it was United Healthcare,
Oh, no.
in the middle of the procedure to say that her patient was denied an overnight inpatient stay.
So what happens in that situation? They just say, "Okay, close up shop?"
No,
I mean,
I
it's
think
just
she did
awful.
the right thing. She finished the surgery. She figured it out after and dealt with it after. But I think she told the health insurance representative, she's like, "I'm actively in the OR with the patient, asleep under anesthesia, operating on them. Like, thank you very much for the call. We will address this afterwards." And the rep was just very robotic and basically was like, "Oh, well, we're not going to approve it. They can't stay overnight. You're gonna have to file a motion and appeal," and kinda just following the steps I'm sure that they were trained to do, but not having that humanistic approach or that logical aspect of like, "Oh, I get it. You're operating right now. This is something that we can figure out afterwards
Yeah,
and hopefully approve for your patient." They need to stay in the hospital for 2 or 3 days.
yeah. Well, there's so many ways we can improve, but so when I started Unite in 2012, um, just talking about improvements, I remember, in the early days that if somebody said they were stage 4,
Right.
that it was when you talk about the death sentence, like, the reply was always like, "Oh gosh," and you're like, just immediately you're just looking at somebody going, "Oh, this person's gonna pass away."
Right.
But then, I remember meeting with the American Cancer Society, and I said something like, when you guys are talking about, like, race for the cure or whatever, does it get frustrating when there's not a cure?
Right.
And will there be a cure? And the gentleman said, and I was new in the world of cancer, but he said, there's just so many types of cancer. So it's not one cure for everything.
Right.
It's very specialized. So I really did come to appreciate that a little bit more on the advances of science because you are seeing in certain specialties improvements. And so now when a woman says they're stage 4, they're living with stage 4, right? I mean, am I assessing
Definitely.
that correctly?
That's 100% true. I will say that there have been so many advancements in the chemotherapies that medical oncology administers, whether that's neoadjuvant before surgery or adjuvant after surgery. The radiation oncologists doing very targeted, shortened versions of adjuvant radiation to the breast. The minuteness of the mammogram or the MRIs and how much they can define like a 5 millimeter cancer. Everything is just moving so much forward and is becoming so detailed, and it's making our jobs all easier. I mean, if you think about people that have maybe stage 4 metastatic breast cancer and they are getting neoadjuvant chemo and having what we call a PCR or an RCR, radiologic complete response, or PCR is a pathologic complete response, the question comes up in the surgery world, do we need to still do surgery on them? They've basically melted away their tumors
Amazing.
with the chemotherapy or the infusions or the immunotherapy. Do we need to still do surgery? We don't have that answer yet, and standard of care is still we do perform surgery even if that is the case, just because we don't have all that data, but it's in the works, it's in clinical trials, people are looking at that, they're analyzing that. I'm sure you heard with the colorectal cancer, in I think it was in England or the UK, they, had, I think, 10 patients, and they took, a pill, and everybody's colon cancer just disappeared. No surgery, nothing else, and so that kind of was in the news and publicized a lot a couple of years ago, and so people are thinking about it more.
Yeah. Oh gosh, that excites me because I do a lot of work with the colorectal survivors and men and women.
I just
Uh,
wanna answer your question about the Mary Bird parking lot while I
oh
have that
yes,
topic.
please, please.
So I just wanted to, give a little shout out to Mary Bird Perkins. In the recent couple of years, they have expanded greatly. They have 20 locations throughout Louisiana, and Southwest Mississippi, and their expansion included, obviously, the North Shore and Covington. In November of 2024, they, started a comprehensive breast cancer specialist program, which includes me, obviously. It includes our breast radiologist, Dr. Rupley, Dr. Morant with medical oncology, Dr. Bermudez with radiation oncology. Um, and then we also have state-of-the-art imaging, advanced breast cancer diagnosis. We have pre-op education, radiation therapy, medical oncology, which I mentioned, and comprehensive follow-up with which not a lot of surgeons, at least, have in the community. I find a lot of patients come in, they were operated elsewhere, their surgeon follow them one time post-op or maybe twice and then just never saw them again, and they just felt uneasy with that. With our, survivorship program at Mary Bird Perkins Breast Cancer Center, we follow patients indefinitely. The most likely time for a breast cancer recurrence is within the first 3 to 5 years, so we follow them every 6 months for the first 5 years, and then we graduate them into a survivorship program and follow them every year thereafter until they say, I feel comfortable. I want to graduate. I'll come back as needed, let's say 10 years down the line. Or if they say, I still feel anxious, I'm 20 years out, I still want to come once a year, we'll meet the patients where they're out at. And oftentimes it's the latter. They want to come in. We've diagnosed cancers 20, 30 years out, even though the most likely time of recurrence is the first 3 to 5 years. There are people that have come back 25 years later with a
Well, and
recurrence.
I think part of that is that you all, we follow all the stories of the patients of Mary Bird Perkins and the great physicians
Mhm.
and team there. I mean, it's always such a pleasure to hear about the positive experiences that everybody has. But I mean, the word that keeps coming up is that it really feels like it's their part of their family. And so part of the reason they probably come back is that you really have provided such a loving, nurturing place for them during their treatment that when they part of the reason Unite exists is that when you're released from that kind of care, you miss that, just that safety net of knowing somebody's looking out after you and giving you a compass. So I'm sure they come back just to know that compass is still pointing in the right direction.
Yes, I'd say a lot. I don't wanna say 50%, but a lot of our, patients that come in after, so many years, it's often a social visit. They just wanna
Mm.
update us on their family, how they're doing, wanna hear about the new advancements in breast cancer, what things are happening now, or they have a friend of a friend that's recently diagnosed even though they're 20 years out and they wanna know how to support them. So, it's just overall a lovely program. I think it's so crucial, to have that and have that access for patients. Because I can say scanxiety is real. I have patients come in, and every single time they get a mammogram every year, they're still worried, even though they don't feel anything. It just brings back that original diagnosis and maybe a little bit of that surprise when they first found out, and it just it's kind of like deja vu, and it comes back, and so they just get anxious and worried.
Yeah, I would say probably the number one topic of conversation in the private group is the scanxiety.
Yeah.
It's constantly, "Pray for me, I'm going in," and it seems like recently, like the outcomes are so much more positive. I mean, people will say, "Oh, everything's good." In the old days, like I said, there was not as there was worse news that was being reported, and we were all sort of as a sisterhood grieving
Right.
seemed like more than celebrating. And now I feel like there is there are more times of celebration for the positive outcomes and the good care that they're receiving.
Definitely. I love when I see patients ring the bell after
Oh yeah.
chemotherapy or ring the bell after radiation, and I told our office, I was like, "We need a bell after surgery to ring the bell." That
Yes.
would be just such a good, just all-encompassing, 360.
Yes. So I want to talk to you a little bit about your podcast that you or your Instagram and your reels and things that you do. That's sort of how I first kind of got familiar with you. It's a really fun Instagram. It's fun and educated. Like it's a mixture that I find very interesting because it showcases your really like there's a funny side of you,
Right.
obviously, a fun and funny side of you, which I think is probably how you stay mentally healthy in a
Yeah.
very serious job. But then it's also very educational and informative. So when did you start that, doing those, and how's it going with that?
Yes. Thank you for asking that. I actually it came about because my sister-in-law, so my husband's little sister, Mary Tuggle, shout out, she actually told me that she's young, she was a lot younger than him, 12 years younger. So she, I think, just turned 30, but she is obviously very involved in that social media generation. And so she had told me that she found one of her doctors on there and showed me their profile, and this was, like, in New York City, and I said, "That's so interesting because I'm kind of at that borderline of social media, but a little bit older generation, I guess, so I'm right in between. I'm 39, so I'll be 40 in May, I guess is fastly approaching, so I'm kind of on I can see both sides of it, and when she had told me that, I said, "That's such a good way to meet patients," and at first I thought most of our patients are postmenopausal. Breast cancer usually is a diagnosis in postmenopausal, patients, but like we talked about earlier, there's premenopausal patients. Maybe they have a hereditary genetic mutation like BRCA1 or BRCA2, and they may be diagnosed earlier. So I thought it was a good way to meet a variety of patient ages and patient dynamics, and so I kind of started it on my own as I was building my practice right out of fellowship. I had a little bit more time, as I was establishing, myself on the North Shore, and so I did it just because I wanted to do a little bit of marketing and outreach, but also I found that there wasn't anybody in the community already doing anything like that. Um, and I think in general, the med influencers really started with plastic surgery and dermatology. A
Mhm.
lot of the cosmetic, pay for service, private practice specialties, because they had to bring in patients basically and do that. But nowadays, you'll see OB-GYNs doing it. You'll see neurosurgeons that are in their 80s still practicing on social media, doing little funny trending reels. And so I saw a whole variety, and I thought it was just a great opportunity to let patients see my personality and then also be educational and tell them, like, hey, these are hot trending topics that we talk about at our annual breast surgery conference. This is what you should, if you're in another state and you're undergoing a diagnosis and you're meeting with somebody, this is what you need to ask your doctor. And these are your options. And I like to sprinkle in a little bit of the advances in surgery because there are a lot. I mean, previously, like decades ago, people were confined to radical mastectomies. They removed their muscle. They had no reconstructive options. Now reconstruction has to be covered legally through insurance. Just like we talked about fertility, moving in that direction. So I think it's so important to sprinkle in that educational aspect.
Yeah, how will people find you on your Insta what is the name?
And my handle is Vera Hendrix MD.
Okay, yeah, and I follow you, so, yeah, everybody follow Vera Hendrix MD because it's really it's not only educational, but it is lighthearted in nature, I feel like. I mean, I feel like it's not too it's heavy-handed in terms of the subject matter is serious, but it's also the way you deliver is the one that you kind of, you wanna watch.
Right, and you try to put it in layman's terms, and sometimes that's hard because you're using all these technical terms, but just explaining to patients. I did a lot of health literacy with Project Healthcare and AmeriCorps before I went to medical school, and so I worked in a basically a food desert in the Bronx, New York, and I did a lot of educational stuff in health literacy, and most people are at an 8th grade reading level, and so you have to explain things that is not medically oriented, not like you're talking to another doctor. You have to talk to most of your patients, which are not always gonna be, medically inclined or have medical professionals in their family. So I try to break it down and keep it simple, but also so they know, what we're talking about.
Yeah. What are some of the areas in your daily walk, in your profession, and that bring you joy?
Oh my gosh. So at work, there's so many. Just seeing patients longitudinally from when they first come in and to after they have surgery or after maybe they're a year out and just seeing that difference and how maybe scared they were when they first came in and everything was so new and there were so many things happening at once and it was overwhelming, um, to after the fact when they're like, "Thank you so much," or "Thank you for convincing me to do the neoadjuvant chemo and the standard of care when I came in saying, like, "I will never do chemo, I would rather die than do chemo."
Mm.
And we have patients that do come in and say that. They may have heard stories from their family or their friends about hair loss and they're a hairdresser or whatnot, and they just come in and they're like, I'm absolutely not gonna do this, or that." And then my goal is always just to give them the most information so they can make an educated decision, and I say, "I never judge. I just want you to make the best decision for you." And Dr. Lagarde always said this, that I've stolen that phrase from her, but there's the whatever decision a patient makes is the right decision for them. And I wholeheartedly believe that. But I always want to give them all the information so they can make that best decision for them. And that includes telling them what the NCCN guidelines say, what the standard of care is, what these new clinical trials are saying. And if at the end of the day they tell me, I've looked at all the pros and cons, I've weighed the benefits and the risks, and chemotherapy is not for me, or radiation's not for me, or I just wanna do the surgery. We have that discussion. I bring it to our multidisciplinary tumor board. I tell them, I talk to the patient, I have the other subspecialists talk to the patient, and if that's what they choose, we never force them to do anything, obviously.
That's really lovely to hear that. The conversation is brought up quite a bit about holistic treatment, compared to, chemo and radiation, as you said. Do you find that if somebody, really does practice a more holistic lifestyle, that their body does respond better when it comes time to is that like, kind of a combination of both modalities?
Yes, I will tell a personal story. So my mom is, like I said, from Ukraine. She is very much into Eastern medicine. She's very holistic. When I was little, she took me to an acupuncturist when I was 12. And so I have that background. My dad obviously is a retired organic chemist, so he's very scientific oriented, evidence-based medicine. So I kind of grew up with that dual perspective my entire life. And so I bring that to my practice, and I definitely like to meet patients where they're at, like I've said. So if they tell me that they've grown up this way or or they have belief systems, whether that's a holistic approach or a more naturalist approach, I always discuss that with them and I tell them this is still the standard of care. I would love to be able to do something in conjunction as long as it doesn't necessarily hurt them in terms of what the standard of care is. But I take that into consideration. That's one of the real reasons why I chose Georgetown Medical School because they had that mind body medicine program. They had cure personalis treating the whole patient, not just a diagnosis.
I think that's important information to share because I think there is the perspective of, just people feeling like that, drugs were pushed on them or something, you know?
Right. I think, yeah, and I think there's a lot of misconception and there's a lot of fear in what's heard on the news or And just going back to your point, there's not one all cure. And so I think a lot of medicine is moving towards individualized, personalized care. We've seen that with melanoma and immunotherapy. We're seeing that with breast cancer. We're seeing that with a lot of the cancers. It's really driven by a patient's individual tumor biology. So just because they're estrogen receptor positive, progesterone receptor positive, ERPR positive, what we call for breast cancer, there's not one all treatment. It's very specific, and those are part of the movement forward, but we're not technically already there yet, just as a society.
I have a 23-year-old daughter. What is the best thing I can do as a mom? At what age do you start instilling in them, some sort of care that can prime them for being very proactive? Like, at what age do you start letting a young girl know,
Right.
Here's what you need to do to be proactive and how and ways that you can set yourself up for better life or results?"
Definitely. I think in terms of breast cancer, there's a lot of discussion back and forth. Should people do self breast exams? They just have clinical breast exams with their provider, like their OBGYN or breast surgeon or PCP? And I think just being familiar with your breasts, knowing if something's new or different, not necessarily saying like every month in the shower at this time you have to do a thorough breast exam. Because for young premenopausal women, a lot of them will have what we call lumpy, bumpy breasts. They'll
Mhm.
have dense breast tissue. They'll feel something. It feels like a mass, but it's just dense breast tissue. And obviously, we always want to be concerned and proactive. And this happens nowadays, even in our patients that are not premenopausal. We always tell them, come in. If you feel something new, if you notice something different with your body, if you feel like something's at all out of whack, just come in. We'd rather you come in. We do same day appointments. We'll do a physical exam. We'll do an ultrasound in our office in real time, which is an extension of our physical exam. And we'll either reassure them there's nothing there, or it's a cyst, which is benign, or let's do some further workup. Let's get some more imaging, like a diagnostic mammogram or whatnot. So I think for the young patients, being familiar with their body, with their, especially in terms of breasts with their breasts, and then knowing their family history, coming in to do a consult, whether if they have a breast surgeon in their community, we calculate their risk score, we see if they're at that high risk, and then we put them in our high risk screening program with the mammogram and the MRI.
So, the high risk assessment is just answering questions?
Exactly. Talking about family history, when did you get your menstrual cycle? When did you go through menopause if they're not young, premenopausal? Have they ever been on hormone replacement therapy? Do they have their uterus? Have they had a hysterectomy? All those questions take into account and we calculate a score.
And is there an age that that starts at?
No, not necessarily. I'd say I've had patients as young as like 18 all the way till like 98,
Wow,
obviously.
because my mom is a breast cancer survivor, and I have never been tested for the BRCA gene. I feel like I should. It's part of me. I probably represent some of the people that are scared to find
Right.
out and what that means for my daughter. What would you I mean, I know you're not allowed to necessarily give me advice as,
Yeah.
just
As a
dispense
patient.
for yes, as just a friend on a podcast, like, what should do you suggest that I do anything in that area since it's knowing my family's history?
I think the first step is coming in for a consult, just meeting with a provider, and then just kind of going through that questionnaire, getting a score, whether and we have patients come in. I have a family, and they have some of the family members have been tested, but there's a large group that has BRCA, and the other family members don't necessarily. They're not ready to test, so they come in for the high risk screening. They come in once a year. We do a physical exam, see if anything is new, any new family histories of any cancers, order their imaging, and they don't wanna test, and that's fine. It's kind of going back to meeting patients where they're at when they're ready, and, in a year or 2, they come back and they test, and they are BRCA positive or whatnot, and then we continue the high-risk screening. We might mention talking about risk-reducing mastectomies. Usually, that's when patients are done childbearing, if that's the case, around 40. We can talk about that. If they're a little bit younger, usually it's high-risk screening, imaging, office visits. So I think in your case, with the family history, I think just meeting with a professional or provider, seeing what your risk score is actually, because it might not be above 20%. You might not need high risk screening, or you may, and that may be something that you want to take up and not do genetic testing and or do genetic testing. I will say the genetic testing is great because it doesn't just test for the genes for breast cancer, it tests 70 different genes. You're predisposed to colon cancer or pancreatic cancer or different things, and it can help you know that you have to get a colonoscopy sooner or more frequently or whatnot, or establish care with a GI doctor.
These blood biomarker tests or
These are the genetic tests, so, like Myriad, Invitae, GenPath, Natera, all of those. It's, either it's a buccal swab, a spit test, or a blood draw. It takes about 2 to 3 weeks to come back. We offer it to all our cancer patients, and it's usually covered by insurance, and then if a patient tests positive or if they have a first-degree family member of a relative that has a diagnosis of cancer, usually that's also covered, and if not, I think the max out of pocket's like $249, which is great because a couple of years ago, it was like $3,000 for genetic testing or
see
5,000.
progress. We wanna hear about
Yeah.
progress. Do I feel like I've heard this before, but, some of these services are available through your mobile screening, is that right?
Yeah, so Mary Bird has a mobile van, they do screening, they have a mammogram in the mobile van, and they can put you in touch with providers thereafter, to follow up on the results or with a genetics counselor we have at Mary Bird as well, and a lot of the genetics, companies have their own genetics counselors as well.
So if you can't get to a Mary Bird location, you could go on the website and find out the mobile,
Yes, where the
van?
mobile van is, like, usually they're at different events on different dates, and you can go there, it's completely free. Mary Bird does a lot of philanthropy, which is great. They do a lot of giving back to the community and patients, which reminds me I'm part of the Echo Alliance, which you should join.
Oh,
It is a group of women on the North Shore that are moving cancer forward, raising funds for cancer, and we meet about monthly and do different activities. Like we went to the Art Association downtown Covington and we made little stones with supportive messages on it that we gave to patients. We had a brunch at the Beauchamp Country Club talking about mental health with a psychiatrist that was part of the group. So it's just really lovely things. We did Thanksgiving fundraiser, Christmas holiday drive.
oh, I'd love to learn more about that,
Yes, I'll
yeah.
have to tell you about this after.
We have such a good community, and I wanted to thank Mary Bird, Perkins for they've been supporting us since day one when, they were the very first group that I visited when I said, "I have this idea." I didn't really know what I was doing back then, but I just knew that I wanted bring women together to find support, and, I went in and, met with Leslie Landry back in the day. I don't know if you remember her. She's now with North Shore Community Foundation.
Heard of her, yes.
But so that's when that relationship started and with Dr. Socks and just a beautiful relationship going forward. So I wanted to thank them for our support, which makes our mental health programs possible. So we're almost finished, but I wanted to find out from you how important is the mental game when you are diagnosed?
So I think it goes back to your question about holistic approach, diet, nutrition, exercise. I think everything in moderation and take into account every different aspect of a person. And so I think having a good positive attitude is so important in outcomes. If you talk to Dr. Moran, she's a huge proponent of exercise. We have a nutritionist at Mary Bird. We have Tai Chi classes. We have yoga classes, we have support groups. I think, those are all really important key factors, not just your family, and sometimes you don't even wanna tell your close personal family, you wanna talk about things like this with somebody else who's gone through it or has a breast cancer diagnosis, and you can find those people at the support groups or with Unite, and just having your class or group of girls or boys, join you in whether it's one aspect of it, whether it's surgery or chemotherapy or all aspects of it.
And I have just two more questions for you.
Yeah.
First, when you come to a Unite event and you see your patients on stage, can you describe what that feeling's like for you as a physician?
It feels like amazing. I don't know if you've seen those social reels where they have the high school students opening the emails that they got into college or not, and it's
Mm.
like that anticipation, which is all the build of how you've seen the patient through their journey before they get on that runway with Unite in their, beautiful glamorous dress. They're super confident and so happy, and they've overcome such a huge hurdle, and now they're walking on that stage. So for me, it's just such a full circle, and it's just so elating, and it makes me so happy, And it kind of brings me back to residency when you had those really hard days when you were on 30-hour call shifts every 2 nights and you were sleep deprived and you think about, that consult you're seeing in the ER at 3 AM after being awake for so many hours, that's somebody's, mother, father, sister, brother, that's a family member, and you have to think that's your family member. How would you want your family member to be treated at that moment? And so I think that's what brings me back, and seeing that patient on stage making it through everything that they have had to overcome and just shining is just such a light.
Yeah, there's many facets of cancer when it comes to impact, not only for the patient, the immediate family, but then it does extend into the community, into your place of work, into your school, into your care team. And for me, I love knowing, and I hope this is something that we do, is that we bless you so that you guys can say, okay, we're doing this. Like we're seeing the good side of what could be a very scary
Right.
disease.
Right. I always tell patients breast cancer is one of the best cancers you can get if you have to have cancer because it's not usually what Dr. Lagarde says kills a patient.
Mhm.
It has such a good prognosis. It's not um maybe like a glioblastoma or pancreatic cancer where, people would think of it as a death sentence because we've come so far. It affects 1 in 8 women, 12% of the population. It's so widespread. There's a lot of attention on it, which is a great thing. And so I feel fortunate to be a breast cancer surgeon and just be able to have that good outcome just from my training, but also from the everything else that's going on around me in science, research, and development to be able to have that wonderful outcome for our
Yes.
patients.
Yes. Well, I hope to see you in October. If you could shout out anything to the world right now, a message, something that drives you, your passion, anything, what would you wanna say?
I always remember this when I was studying for exams and things were very tough and hard, or when I talk to patients, I always tell them other people have done this and there's no reason why you cannot do this. And so I just feel like that's a motivation factor for anybody, whatever they're going through, to know that other people have walked in their footsteps before and made it out okay and even shined and were better than themselves before the diagnosis. So I think that's important to keep in the back of your mind or in the forefront and move you through.
Yeah, that is so true. The ladies who sign up for Unite, they come in so scared and they're in their own individual space, and then all of a sudden they're in a community, and then they get their power, but their number one motivation is, "I wanna use my story to bless others. I
Yes.
want people to see that" one of my physicians said, "I wish there was a Unite sister alum in every single doctor's waiting room so that they could say, 'I've been there. You're gonna do this. I gotcha.'"
Yes,
You
yes,
know?
I would love that. How can we
Right?
institute that?
Exactly. Let's
With
figure it out.
more philanthropy funds.
Yeah, exactly, or just
Yes.
more beautiful volunteers, which Unite has so many. So, thank you so much for being our guest today on the Still I Rise podcast, and I learned a lot from you, and I just can't wait to continue following you, and I'm so happy we got to meet on this level.
Yes, me too. Thank you so very much for everything that you do for our patients, for our community, for having me even be on this podcast is an honor and a privilege, honestly.
Thank
Thank
you.
you.